afternoon, everybody. So you're joining us today at BNMS after we've had a really interesting series of talks on Theranostics from some very esteemed speakers today. Today we have Fahim with us, Ozgul from Istanbul, and Akram from Jordan. And we're going to be just having a little chat today about Theranostics. So thanks very much for joining us today. I think we agree they were very interesting talks that we had and asked a lot of questions for us. So if we get the ball rolling, Fahim,
sure.
We'd just like to, iodine 131 therapy, and thyroid ablation has been around for many years, as early as the 1930s, really, hasn't it? And it's changed a lot, but even in a very short space of time. And if you can like to describe to us, in the last 5 to 10 years, how do you feel the practice of thyroid radioablation has changed in 2026?
So from 2026 perspective, basically, when I started nuclear medicine around 18 or 20 years ago, we used to ablate everyone with a higher activity or a fixed activity of 3.7 gigabecquerels. So the new evidence have emerged with lots of prospective trials, iron trial, Estimate trial, Hilo trial, and for the first time we had lots of phase 3 trials which actually give evidence in real medicine, just like any other oncology treatment. And it has shown that low activity of iodine, that is standard is 1.1 gigabecquerel or 30 millicuries, is as good as 3.7 gigabecquerel in low risk differentiated thyroid cancer. The other trials have also shown that in selected patients from PT1 to PT3, and sometimes with N1A, so sentinel node, I'm not talking about N1B disease, has also shown that some patients do not need iodine, so we do not need to ablate. Now that has changed a lot of practice. So basically, you are not treating patients for things which are not going to help them in the future, rather than can give them some side effects. So that has been a major paradigm shift between practicing nuclear medicine for ablation 10 or 20 years ago. The other things which have really changed is also the intermediate risk patients. So in some of these selected intermediate risk patients, you do not need to treat iodine. You can monitor them with surveillance, and if needed, then you can always treat them. The third thing which is persistent is that the metastatic disease, as far as the disease is iodine avid, you could treat them. And the fourth, I think the most important thing is basically about the radioiodine refractory disease. So 20 years ago, you do not have much treatments. Now you have got a plethora of knowledge from the genetic markers, which you can target the disease with several kinds of TKIs. So in modern thyroid clinic, or in modern MDT, or the modern histopathologist will give you a lot of genetic markers right at the beginning. So later in the course of the disease, if the disease declare itself as radioiodine refractory disease, either in a near or a distant future, you have got drug targets like lenvatinib, like sunitinib, and then followed by second line as cabozantinib, and for RET fusions you have got basically selpercatinib, which was FDA approved in 2024. So I think from my talk, basically the major changes are, please do not treat low risk thyroid cancers. Take a view for intermediate risk cancers where there are some aggressive features, and continue to treat the high risk cases. And obviously all these decisions are made with patients, with MDTs, and the rest of the experts within new settings. So in UK, we finished our trial and published it a year or 2 years ago, and then we had a UK consensus expert consensus how we drive the results from the iron trial into the modern medicine, and we have published a paper, and that shows actually that PT1 and PT2 diseases now can be safely omitted as a treatment, not to be treated as an ablation line first. And then you can safely follow these people for patients for 5 years and discharge them from the clinic back to general practice or to their primary physician wherever in the world you're working. Yeah. Thanks.
No, thank you. So it sounds like it's got a lot more personalised treatments, yes. But it certainly sounds it's getting more complex as well.
So it's much more complex. So basically, when I started it, everyone used to get total thyroidectomy, 3.7 gigabecquerel, lifelong TSH suppression. The one thing which I haven't mentioned is basically the TSH suppression is not also lifelong. You do not suppress anyone's TSH if you are not treating them with iodine. And the TSH suppression can be quickly gone down after you have done dynamic risk stratification in 9 to 12 months post iodine ablation if you are treating these patients.
Yes. Yeah. and has that had much impact on your patient clinics and your throughput?
Yes, but it obviously, with every change, it brings new challenges. So the new challenges are basically, first is how to discharge those patients who have been coming to clinics for 20, 30 years. So you have to have a strategy. The second is those who you are not now going to give treatment, where are they going to go for the next 2 to 5 years for monitoring? And the third is basically clear instructions to the GPs when you are discharging these patients, because lots of these patients may have very low calcium actually, so they have developed post-surgical hypoparathyroidism. So you need to have a clear instructions regarding their calcium regulations, their TSH regulations, back to the GPs, and in some cases you continue to follow them in endocrine clinics not because of thyroid cancer, but because of that they can have severe hypoparathyroidism post-surgery.
Yes. So there was an excellent talk on alpha therapies and combination treatments as well, and it was really interesting to hear your experiences in Istanbul. So if you would like to just describe about alpha therapies and sort of how you feel they've started to impact on patient care in Istanbul.
Yes, I would like to speak in general because alpha therapy is really the new kid on the block. So I think everybody is still learning. We have many ongoing clinical trials, and we need to still understand the real effects after seeing these respective data. So from my perspective, alpha therapy is a strong thing to use for the patients who are resistant to all treatment modalities. So I think since it is really powerful, we have to use it wisely.
Yes.
But also there is another point we should consider. There are still limited supplies, and it has some financial burden on the patient, on the healthcare system. So I think even it is really promising, we should be taking these steps slower than we might take with other therapy agents.
I think you're absolutely right. I think when you've got the new kid on the block, it's very tempting to play with the new toys
Exactly.
before you think, have we gone too far?
Yes, exactly.
Isn't it? And you've mentioned some interesting points about the challenges about actually supply, which we'll talk about later. But are there any other challenges that you have found in your team's experience with using alpha therapies?
Yes, mostly prostate cancer patients. We see xerostomia, especially this is a challenge. But we have we use some kind of comforting strategies in our clinical practice. So I think in the next steps it will be less important, and also those adjustments which concludes to precision in medicine. So each patient is different. So we should act to each patient differently, maybe adjust dose or adjust other strategies or combination therapies. So I'm sure Akram will talk more about that. So I think we should act in terms of patients' safety and the degree of the disease and other things we can all explore with the patient.
Yes. Well, I think that comes down to that form of precision medicine and personalised medicine, which I think gives nuclear medicine its unique strength, isn't
Exactly.
it, that you described? And you mentioned in your talk about combination therapies as well, or tandem therapies. So what sorts of examples do you think might have potential benefit going forward?
Starting again with the prostate cancer, combining beta and alpha emitting agents, especially lutetium, PSMA and actinium-225 therapies, decreasing the dose, co-injecting the patients. So these are, I think, the strategies we will use more in the past, but we will still need more steps or more experience to take to understand the real efficiency. But so far the results from the clinical trials are really promising.
Yes. And you mentioned also about immunotherapy as well, because that seems to be a bit of a game changer in the oncology world as well. And do you think there's much prospect for that with immunotherapy?
I totally accept that. I mean, I haven't seen many patients with combination therapies like immunotherapy, but so far I really look forward to see the results of the ongoing clinical trials.
Yes. Dr. Alibraheem, so thank you very much. So we're very honoured to have you present with us in this panel as well. So you gave a very good talk about kind of the global picture with Theranostics and where we need to be going with that. And it seems in Jordan you really are at the front of the pack in a lot of the things that you've managed to bring through. You mentioned you're already doing actinium PSMA and you're even doing lutetium FAPI as well, which is absolutely amazing, frankly. You tell me, I mean, obviously you've had a lot of successes, and have there been any challenges that you've found getting some of these more novel treatments into clinical practice in Jordan?
Thank you, Anver, for having us in this postcard. Actually, yes, there are challenges, but I have an important message. Don't wait that everything should be optimized to start. You have to start, okay? Sometimes you have to utilize your resources according to the resources in your country and in your region and just establish this service. This comes after believing in our tools and in our radiotheranostics approach. And actually, I would say right now, radiotheranostics is not an innovation or scientific success. It is better findings of nuclear oncology. And we have very well established data in literature that it is a practice changing, for example, in the prostate cancer and in neuroendocrine tumor. And this is very important for us as a nuclear medicine physician when we start the discussion with our colleagues from the oncology department, from the radiation oncology, and even with the administration of our hospital about the value of this new approach in fighting cancer. And one important findings when we look to all studies about radiotheranostics is the favorable safety profile. Also, this encourages us. Actually, when I started in Jordan, I started under early access and compassionate use. It wasn't well-designed clinical trials because giant pharma doesn't include low and middle-income countries in phase 3 trials. So we have to start it. We have to offer this new hope for our patients. And we succeeded in that. And actually, as I mentioned in my presentation, those patients who were treated with lutetium PSMA or actinium PSMA, if these treatment options were not available, they would have been referred to palliative care only. In many patients, we achieved almost complete response. Quality of life improved significantly. And really, patients and family thanked us as nuclear medicine physicians, and we were able to make a real change to the best of the patients. Okay.
Yes. No, that's very inspiring, and thank you very much. And you made a very good point about almost inertia for perfection, when actually
don't wait to be everything is
get on with it.
You have to start, but also to make sure that you have a quality system in place. This is very important.
Yes.
First of all, not to harm.
Yes.
First of all, not to harm. When you make sure that your radiochemist or your and technologists and physicists, they know their work very well and they are scientific in their approach according to available evidence, you can start.
Absolutely. Well, no, thank you very much for that. Well, and thank you very much, everybody, for taking the time to speak with us today. It was an absolute honour and a pleasure. And we hope you enjoy the rest of the conference. And we look to hear more from you in the coming future and the future of Theranostics.
Thank you, Anver. Thank you very much.
Thank you very much. Thank you.